Procalcitonin PCT and C reactive protein CRP. PCT and CRP are key tools for assessing inflammation and infection. They are both biomarkers that signal inflammation in the body, but they have distinct characteristics that make them useful for different purposes in clinical practice. A comparison of the two biomarkers to highlight their fundamental differences. CRP versus procalcitonin, a clinical comparison. Feature: C-reactive protein, CRP. Procalcitonin, PCT. Primary role: a general, nonspecific marker of inflammation. It confirms that inflammation is present, but not its cause. A more specific marker for bacterial infection, particularly systemic infections like sepsis. Physiological trigger: produced by the liver primarily in response to IL-6, a general inflammatory cytokine. Produced by many cell types in response to bacterial toxins and specific inflammatory signals like IL-1 beta and TNF-alpha. This release is blocked by interferons released during viral infections, which adds to its specificity. Kinetics: rises within 4 to 6 hours, peaks at 36 to 50 hours. It has a longer half-life, so it falls slowly as inflammation resolves. Rises faster than CRP, within 2 to 4 hours, peaks at 24 to 48 hours, and has a shorter half-life, so it decreases quickly as a bacterial infection is controlled. Specificity: low, elevated in almost any inflammatory state. Infection, viral or bacterial, trauma, surgery, cancer, autoimmune diseases, like rheumatoid arthritis. High, primarily elevated in significant bacterial infections. It remains low in viral infections and many non-infectious inflammatory conditions, making it useful for differentiation. Typical thresholds: normal, less than 1 milligram per deciliter, or less than 10 milligrams per liter. Mild/viral inflammation, 1 to 10 mg/dl. Severe/bacterial infection, often 10 to 20 mg/dl, and can be much higher. Less than 0.1 g/l. Bacterial infection highly unlikely, strongly discourage antibiotics. 0.1 to 0.25 g/l. Bacterial infection unlikely, discourage antibiotics. Greater than 0.5 g/l. Bacterial infection likely, strongly encourage antibiotics. Clinical applications: screening for general inflammation, monitoring disease activity in chronic inflammatory conditions, e.g., rheumatoid arthritis, vasculitis. Assessing cardiovascular risk using high-sensitivity CRP or hsCRP. Diagnosing and risk stratifying sepsis. Differentiating bacterial from viral infections. Guiding antibiotic therapy, starting and, crucially, stopping antibiotics safely. Monitoring response to antibiotic therapy. The interpretation of both CRP and PCT is most powerful when combined with a full clinical assessment. Neither test should be used in isolation to make a diagnosis. CRP as a sensitive red flag. CRP is an excellent, affordable, and sensitive screening tool. Its strength lies in its ability to confirm the presence of inflammation. PCT as a specific guide. PCT's main power is its specificity for bacterial infection. This makes it an invaluable tool in situations where distinguishing between a bacterial and a non-bacterial cause is critical, such as in a patient with a severe respiratory infection or suspected sepsis. Guiding antibiotics. The most well-established role for PCT is in antimicrobial stewardship. The fact that PCT levels drop quickly as a bacterial infection is brought under control allows clinicians to use it to decide when it is safe to stop antibiotics. Not a perfect rule-out. This is a crucial point of caution. While a low PCT is reassuring, it is not a perfect rule-out test for bacteremia, bacteria in the blood. This is particularly true for certain types of infections, such as those caused by Staphylococcus aureus. Therefore, in a patient who looks septic, a low PCT should never be used to withhold antibiotics. Using CRP to predict PCT. Because CRP is faster and cheaper to measure, some research has explored whether it can be used to decide when to order a more expensive PCT test and summary. Think of CRP as your general check engine light, signaling that something is wrong. PCT, on the other hand, is a more specialized diagnostic tool that helps you determine if the problem is likely a bacterial infection and helps you manage the use of antibiotics.